Hi doctor, I'm Ritika from Io. It's an honor to have
Hello.
you on our platform. First, I would like to introduce our company, Io and Love Heals Cancer. We guide cancer patients in their treatment journey. Our company aims to extend the life and improve the quality of life for cancer patients through an integrative oncology treatment, which includes both medical treatment and complementary treatments. We provide end-to-end care to patients and also help with counseling, healing sessions, Ayurveda, medical cannabis, anti-cancer diet, awareness session, and pain and palliative care. This session is going to be all about spreading awareness and educating cancer patients. And for that, we have Dr. Salil with us. Let me take this opportunity to introduce him. Dr. Salil is a super specialist in the field of oncology. He has completed his DM in oncology, hematology from Asia's premier cancer institute, Gujarat Cancer and Research Institute. He's well renowned as an expert in diagnosing and management of cancer and an expert in chemotherapy, molecular targeted therapy, hormonal and immunology treatment. He has also numerous national and international publications in various conferences to his name. He has over 8 years of experience in the medical field. It's an honor to have you with us, doctor. Thank you for taking out time from your busy schedule to do this session with us.
Thank you so much.
And I'm sure a lot of queries will be answered through this session. So is there something that you would like to say before we start with the questions?
No, you got it spot on. So I'm a DM medical oncologist. I am currently practicing with Apollo Hospitals. I'm a consultant at Apollo and a director at Oncura Cancer Clinics. And I think you got the rest of it spot on. So we can move on. Please go ahead.
Okay, doctor. So my first question is, can you please explain more about molecular targeted therapy?
All right. So imagine something like this. You have cancer, which is multifactorial. The cause for cancer is something we don't know really. We assume or we know that cigarettes cause cancer, alcohol causes cancer, some forms of radiation cause cancer, right? So there are multifactorial reasons why cancer occurs. Now, the treatment of cancer up and until now, up and until perhaps in the last decade or so, used to primarily involve chemotherapy, surgery, and radiation. Now, the chemotherapy part of it was a blanket chemotherapy. What that meant was that you gave certain drugs which are cytotoxic, certain drugs which were poisonous, and they killed the cancer cells, but they also killed other normal cells in the body. That's the reason why your patient ended up with hair loss, because it used to damage the hair cells. You ended up patients having diarrheas because it damaged the GI, the gastrointestinal tract, normal cells in the GI tract. Is the reason why your patients develop anemia and thrombocytopenia, means they develop a fall in their hemoglobin and fall in their platelet counts. It's because chemotherapy is by and large not specific. It's a blanket therapy which kills the cancer cells, yes, but it also kills other cells. Now, what we realized in the last decade or so is that every cancer has certain proteins on its surface, right? Now, these proteins, if they can be targeted, then you end up killing only the cancer cell. You end up killing or particularly targeting the cancer cell without damaging the normal cells. So one of the most excellent example of that is a type of blood cancer which is known as CML, chronic myeloid leukemia. Now, the chemotherapy that was used to treat chronic myeloid leukemia or CML had a success rate which was very low. So the 5-year survival rate was only around 15%, which means that if you had 100 patients with CML who were treated with chemotherapy, only 15 out of these patients were alive at the end of 5 years. Then came a revolutionary drug known as imatinib, which is a perfect prime example of molecular targeted therapy because it targeted a particular molecule or a particular receptor on the surface of the cancer cell. In this case, it was a tyrosine kinase inhibitor. Now, this molecular targeted therapy was so precise in its action that it changed the 5-year survival rate from 15% to more than 95%. So today, because of molecular targeted therapy, and in this particular case, imatinib, which is just an oral drug, you have patients with chronic myeloid leukemia, a form of blood cancer, in which if 100 patients were given this drug, at the end of 5 years, 95% of them were alive. So that's the kind of impact molecular targeted therapy has. Molecular targeted therapy is basically the evolution of precision medicine. It is individualized treatment where you treat each patient based on the specific genetic mutations that that particular patient has, which makes his cancer different from any other person's cancer. So it's personalized cancer treatment.
It's a huge advancement from what we had, 15% to 95%. That's a huge gap.
Absolutely. Yes. It's a fantastic breakthrough.
Exactly. Like usually people aim for improving a little bit, but 80% of the improvement, that's a huge thing.
Absolutely. So, for example, in lung cancers, you had patients who were in stage 3 and stage 4, especially lung cancers, who had survivals of, something like a couple of months to maybe a year or a year and a half on chemotherapy. And today you have lung cancers where you have molecular targeted therapy based on certain mutations known as EGFR, AL-cross, etc., where you have them just on oral tablets, and you can have the person, if he has the right sequence of mutations, they're alive for 4 years and 5 years and 6 years and come walking. I've had patients whose PET scans were absolutely filled with cancer. I've started them on oral treatment, oral molecular targeted therapy, and patients have come back walking with their PET scan showing completely resolved disease. And this is stage 4 cancer. So now you have patients with lung cancer in stage 4 who can live for 4, 5, 6 years and counting. So that's the kind of impact molecular targeted therapy has had.
Doctor, as chemotherapy, you said that it has so many side effects. So what about the side effects of molecular targeted therapy?
It's significantly lower. The reason simply is because, like I said, chemotherapy is a blanket therapy. It targets every cell in the body, which includes cancer cell and non-cancer cells. Molecular targeted therapy, on the other hand, is particularly targeting the cancer driving mutation. So if you're not damaging the normal cells, the side effect profile is far lower. It's not that there are no side effects. Of course, there are side effects, but it's significantly lower than the kind of side effects you expect with chemotherapy. So it's much more easily manageable.
That's a good news, doctor, for all the patients.
Let me just, if I may, extend on that. So if I have a patient with who's receiving chemotherapy for lung cancer, I expect hair loss, I expect fatigue, I expect nausea, I expect vomiting, I expect diarrheas, I expect the counts to fall. He might go into cytopenias, anemia, thrombocytopenia. His WBC count might fall, leukopenias, which might increase the risk for infections. But the same patient, if I have him on molecular targeted therapy, for example, on a drug called as gefitinib or afatinib or any of those oral drugs, the only problems he'll probably have is maybe a bit of diarrhea and rash. And that's about it. Majority of and that will also be easily tolerable in more than 95% of the cases. So the side effect profiles are incredibly manageable.
Okay, doctor. Also, along with this, can you please tell me the difference between hormonal and immunology treatment?
Yeah, they're vastly different. So there are certain cancers which are hormone dependent. For example, breast cancer in women, breast cancer, ovarian cancer, cervical cancers, uterine cancers. These are hormone dependent cancer. What that means is, for example, in breast cancer, estrogen is a hormone, or progesterone is a hormone which drives the growth of the cancer cell. It acts as a fuel. It's like adding fuel to the fire, right? Similarly, for ovarian cancer, there are hormone receptors. And for men, for example, in men, prostate cancer is hormone dependent. So testosterone is the hormone which drives the growth of the cancer cell. All right. So these are hormone dependent cancers. So one way of treating these cancers is to give drugs which block the hormone production. For example, in breast cancer, there are drugs known as tamoxifen and letrozole, which are anti-estrogen drugs. Then there are certain drugs which directly target the estrogen receptor, for example, fulvestrant. So these are hormonal agents, right? Similarly, in case of prostate cancer, you have one of the easiest ways to deal with metastatic prostate cancer is to undergo an orchidectomy, which means you actually operate and remove the testis, because the testis is where the hormone testosterone is produced, and it acts as a fuel for increasing prostate cancer. So you do a surgery for the testis, or you do a medical orchidectomy where you give injections which will suppress the testosterone production. So these are hormone dependent cancers where hormonal treatment basically aims to stop the production of these hormones which fuel their growth. Immunotherapy, on the other hand, is something which is groundbreaking, which has only come in the last few years, and it's a special area of interest of mine, immunotherapy. So immunotherapy works incredibly different. Immunotherapy basically is reprogramming your body and making your body realize that the cancer cells are not your normal human body cells, but these are foreign body cells, or at least you should treat them like foreign body cells. Basically, what happens in cancer is whenever you are susceptible to an infection, maybe a bacterial infection or a viral infection, your immunity fights back. Your immunity, which mainly consists of white blood cells, they develop an immune response which fights against the infection, or in this case, fights against the cancer. That's what usually happens. But what happens in certain cases is you develop mutations, and because of these mutations that occur in these cells, the cancer cells are able to evade the immune system. They're able to escape the immune system. They're able to escape the T cells, which believe that the cancer cell is the normal human body cell, which is reproducing, and so they don't attack it. What immunotherapy does is it basically reprograms your T cells, it reprograms your white blood cells to go and tackle or go and attack the cancer cells. Your cancer has certain, it's a little complicated, but your cancer cells have certain receptors on their surface known as PD-1 and PD-L1. These PD-1 and PD-L1 receptors help them to escape from the normal immune response, which is mounted by the T cells. What immunotherapy does is it reactivates the immune T cells, and it reminds them that the cancer cell is not a normal human body cell. We must target it and we must kill it. So immunotherapy works fantastic. I have very, very old patients whom I have put on immunotherapy, and they have tolerated incredibly well. All right. And we are learning more and more where immunotherapy can be applicable. So once upon a time, we believed it only worked for melanomas, which is a type of skin cancer. Now we know that immunotherapy works fantastic in melanomas. It works fantastic in lung cancers. It's the first line treatment for kidney cancers. There are Hodgkin's lymphomas. I have had patients who have not responded to first and second line chemotherapy. And maybe 5 years back, we would have said that these patients are not going to make it. They have relapsed even after transplant, some of them. And we say that this patient is going to die. And Hodgkin's lymphomas are such young patients. Today, I have a patient who had not responded to any form of treatment. I put him on immunotherapy and his cancer just melted away. Immunotherapy is a groundbreaking science. We are learning more and more about it. We are still learning about the new indications where immunotherapy is applicable. And every year we find out more and more areas of cancer where immunotherapy has a role to play. But immunotherapy is a completely different way of science and different way of approaching cancer than where we have ever done before. So I have great hopes from immunotherapy. Let's see how it plays out.
Doctor, as I've heard that when usually people have cancer, as you said that it's the only treatment, like people only know about chemotherapy, surgery or radiation. So it's still less known about immunotherapy and hormonal treatments in India.
Absolutely. So there are two reasons for that. Hormonal therapy, I would say a large number of people are on hormonal therapy. Immunotherapy, you're right. There are two aspects to this. One, that immunotherapy is something upcoming. So, people yet need to be aware of this option. People need to, in fact, go up and ask their doctors about this. I try and always make it a point to educate my patient so that he realizes what the options are. Patients now are getting more and more smart where they come up and do ask me that, I don't want to do chemo. Are there other options available? So there is awareness more than before. The second more important problem is that immunotherapy is ridiculously expensive at present. So the majority drugs which are made by only a few companies which hold the patency rights. All right. So it's very difficult to procure these drugs for the general public as of yet. So for every, say, 10 patients whom I advise immunotherapy or who would be the ideal candidate for immunotherapy, there will be only around 3 of them who will actually go on to take the immunotherapy because it is so expensive. Okay. But that will change. All the drugs that first came out in the market were ridiculously expensive because the companies which made them had patency rights. But in the next 4 years, I don't want to name any pharma company, but in the next 4 years, 2 of the biggest pharma companies are going to lose their patency rights on 2 of the biggest immunological drugs in the world, right? So things are going to change. And once they lose their patency rights, you're going to have a large number of biological similars, which are going to be made by companies, which are going to bring the prices down significantly. So that's going to be a huge boon. The other reason is that people are confused about what immunotherapy is, and there is alternative medicine and there is a scope for alternative medicine, but somehow immunotherapy gets exploited a lot. Okay, you have a lot of centers which practice so-called immunotherapy, which is just outright fooling the patient. They are not even FDA approved things that keep going on in the background, and people are desperate when it comes to cancer. Unfortunately, people reach that point where they are willing to try anything, especially in a stage 4 metastatic cancer. And I understand that. But then there are always people around the world who are, trying to exploit that desperation. So in the name of immunotherapy, in the guise of immunotherapy, a lot of hopscotch, ridiculous treatments go on. I know so many patients who have fallen prey to this. So you need to be very aware. You need to go to the right person to take the right treatment.
That's why we are having these sessions to spread awareness about more number of treatments available to them. So doctor, can you please shed some light on lung cancers and their treatments?
All right. So lung cancer. So when you talk about any cancer, you basically divide it into 4 stages. That is the most common classification of cancers. A stage 1 cancer is a very small tumor, which generally is easily operable. That's the best. If at all anyone were to end up with cancer, you want a stage 1 disease, which is operated in most cases and removed. A stage 2 is a slightly more larger disease, but in most cases would still be operable. A stage 3 disease, by and large, which includes lung cancer also, is a disease which has spread at least locally. So that usually means that a stage 3 disease is one where there are lymph nodes which are positive. A lymph node is the local areas where the cancer spreads into. All right. So in case of lung cancer, that would be the mediastinal nodes, which is the nodes in your chest cavity. And a stage 4 disease is one which is metastatic, which means it has spread through the blood or the lymph. And if you were to remove a PET scan, if the person had a mass in the lung, and then you found also that he has disease in the liver or in the bones, that's a stage 4 disease, which by and large is not curable. I have a few stage 4 cancer patients whom we have cured. They are known as oligometastatic stage 4 cancer patients, which means they have very limited stage 4 disease. But by and large, stage 4 cancer is not curable. But the amount of lifespan that can be achieved now in a stage 4 metastatic cancer patient has improved tremendously, especially in lung cancer. So stage 1 and 2 lung cancer, I would operate. Stage 2, 3, an advanced stage 2 disease, stage 3 disease, I generally give them radiation along with chemotherapy. That's known as concurrent radiochemotherapy. All right. So I use a combination of radiation along with chemotherapy, and we still try for cure. And many of these patients will be cured. Stage 4 cancer patient is a patient who, unfortunately, in most cases, not all, but in most cases will not be curable. So now a stage 4 cancer patient, our aim is to improve his quality of life and to take and improve upon his lifespan as much as is possible. Now, like I said before, until a couple of years back, the only option in stage 4 cancer was chemotherapy, which basically brought you a lifespan of somewhere between a couple of months to maybe a year, if you were really lucky, a year and a half. Today, on the other hand, in lung cancer, you have options such as molecular targeted therapy. Why? Because you target certain driver mutations. Every cancer occurs because of certain mutations. What these mutations do is these mutations which take place in the cell cycle, they promote immortality among the cancer cells. So the cancer cells don't die anymore. They just keep on reproducing. They keep on growing. So this immortality which occurs because of mutations, it targets these mutations. All right. These mutations are known as driver mutations. So in case of lung cancer, there are certain, without getting too technical, there are certain mutations known as EGFR, ALK, and ROS. And if you can target these mutations, which you can now target with just oral drugs, oral tablets, it works far better than chemotherapy. It works fantastic. It has side effects which are minimal as compared to chemotherapy. And you can increase the lifespan of a patient from anywhere between 2 to 3 to up to 5 to 6 years. So that's incredible. I have patients. I remember I had this is just a week back. I had this very young 32-year-old gentleman who came for the first time, a non-smoker. He had told me, he had a 1.5-year-old daughter who's just, and he ended up with stage 4 lung cancer. Now, this is a person who, a couple of years back, I would have very few options. Today, on the other hand, I got his genomic analysis done. I did a next generation sequencing. I found out that he has a targetable mutation, and I have put him on an oral drug. And I'm very sure he's going to respond beautifully. Of course, is it curable? The answer, unfortunately, still no. Maybe someday we might even reach there. But can I really buy him a good quality of life and a good couple of years? That's definitely. Now, the other thing that has happened in lung cancer is immunotherapy. Immunotherapy has come up in a huge way in lung cancer, and I dare not say it. I'm not going to use the word cure, but we have patients in lung cancer in stage 4 who have beautifully responded to immunotherapy with minimal side effects, who continue to remain in remission even 3 and 4 years after treatment, which means that 4 years down, a metastatic stage 4 lung cancer, which has spread everywhere, I've put them on immunotherapy, and at the end of 4 years, their cancer is completely gone and it's still not there. I won't use the word cure because that's a very dangerous word to use in metastatic cancer. But for all practical purposes, the patient has no cancer anymore. And we are still waiting, but the cancer has not come back. It's 4 years. The patients are still alive and doing absolutely fine. So that's the incredible landmark things that have happened as far as lung cancer is concerned.
How does immunotherapy work? Like, is it directly given in the bloodstream or an oral drug?
So in most cases, when we talk about the Immunotherapy, which I'm referring to, which is basically PD-1, PD-L1, CTLA-4 inhibitors, these are given IV. So it's given over maybe a couple of hours, just 1 or 2 hours, in most cases over 1 hour, in fact. Usually once every 14 days or once every 21 days in most cases. And that's it. You just have to come. It doesn't require overnight admissions. It does not require the patient staying in the hospital for too long. It just needs the patient to come to the hospital, spend 2-3 hours, take the immunotherapy, and he's gone home. It's as simple as that.
Okay, doctor, how does smoking affect lung cancer treatments?
Yeah, how does smoking affect? I'm sorry, I didn't get that question.
How does smoking affect lung cancer treatments? If a person is a smoker, then how will it affect him if he has lung cancer?
That's a wonderful question. That's a great question, actually. And smoking does affect, okay, not just lung cancer. Smoking affects every cancer. If the person is smoking, if a person who already has cancer is smoking, it reduces his chances of cure. It increases his toxicity. It increases the adverse effects associated with the chemotherapy, immunotherapy, or the molecular targeted therapy that he's taking. And the overall outcomes are going to be bad. Make no mistake about it. Okay. Now, having said that, what is even more interesting is whether it is gutka, tambaku, chaini, khaini, zarda, bidi, cigarette, tambaku, all of that, right? They have more than 200 different substances which are just made to cause cancer. These are known as carcinogenic substances. Nicotine is a substance which is added just to cause addiction. Now, this must be the only product in the world where you specifically add something just to cause addiction. Nicotine does not cause cancer. Nicotine is just going to act on an area called as the nucleus accumbens, which is an area, the reward system in our brain. And it causes a dopamine surge. And the dopamine surge is what makes you want to crave. Whenever the dopamine crashes, it makes you crave for cigarette. So basically what nicotine done is it causes addiction, and it causes a dopamine surge, which is whenever it falls, you feel anxiety, you feel panicky, you feel that I need to have another puff, or ek sutta marna zaruri hai, that kind of feeling, right? So this is the only substance in the world where you are actually adding something to something that you're consuming so that you remain addicted to it. That's so dangerous. And people believe that it causes oral cavity cancers and it causes lung cancers, which is not true. It does do that, but it does far more than that. It damages the oral mucosa, it damages the lungs and causes lung cancers and oral cavity cancers. But in addition to all of that, it acts at the molecular level, it acts at the DNA level, it causes mutations in your DNA. So smoking not only is going to cause lung cancer, it also causes oral cavity cancers, but it also causes esophageal cancers, laryngeal cancers, stomach cancers, bladder cancers, colon cancers, gastric cancers, kidney cancers, and even blood cancers. So people have this wrong assumption that smoking is going to cause lung cancer. No, smoking is going to cause every cancer in the body because it is going to act at a DNA level, and DNA is present in every cell in the body. The risk of having lung cancer is more than the risk you will have of having stomach cancer. But having said that, the relative risk of having lung cancer is around 18 to 20 times if you are a smoker. But the risk of having stomach or esophageal cancers is still 13 to 14 times higher if you are a smoker. So smoking causes all kinds of cancers, you know, and people need to understand that. And I always get asked this question, कि नहीं वो तो फूकता नहीं था, उसको भी cancer हुआ. तो बात तो सही है, cancer किसी को भी हो सकता है. But if you smoke, your chances are going to be more than somebody who doesn't smoke. That's definitive. That's period. There's nothing to discuss in that or debate, you know. So that's how it works.
There are other factors which work for this, but smoking is a bigger one.
Smoking. So look, there are factors. There is genetics at play, which is huge. All right. Those are things you can't change. But there are things which you can change. Of the things which you can change, I'm sorry, of the things that you can change is the smoking, is the alcohol, is your diet, is your lifestyle. Those are things which you can't change. Yes, maybe I have a strong family history. I can't do much. You can do something about that also, actually, in fact, if you were to discuss genetics in detail. But there are things you can't do something about, and there are things you can do something about. Don't crib about the things you can't do anything about. But can you quit smoking and reduce your risk of cancer significantly? The answer is absolutely yes.
As you were saying about genetics, and we can do something about that.
I'm sorry, just a voice there. Can you go again?
As you were saying about genetics, and you said that we can do something about it. I have heard that in breast cancers, there are some markers, like if there is some heredity in your family, there are some markers that you can get tested for it. So how does that work?
Absolutely. So like we talked about that, you know, all cancers are basically associated with genetic mutations. It's just that we don't know much, right? Science is just coming up. DNA, gene, all of these things, they sound fancy words, but the truth is, and as much as we pretend that we know, there is a lot more that we don't know, right? It's only in the last 15, 20 years that we have really started understanding genomics. next genomic sequencing is hardly just a decade old, and the biggest strides have taken place in the last couple of years, actually, right? But what we do know is that there are certain cancers which are very highly associated with certain gene mutations. Breast and ovarian cancer, for example, is associated with a gene known as BRCA1 and BRCA2. BRCA1 and BRCA2 is clearly, unequivocally associated with cancers, especially breast and ovarian cancer in women, prostate cancers and pancreatic cancers in men, etc. If a female has an ovarian has a BRCA1 or a BRCA2 mutation, the risk of ovarian cancer goes as high as 40 to 60 times, 40 to 60%. That's incredibly high. Similarly, if a female has a BRCA1 or a BRCA2 mutation, the risk of breast cancer goes as high as 20 to 40%. That is very, very high. So it's very important to know if we can find these people in advance, because if we can do that, then we can prevent these cancers from actually occurring in them by doing something. In case of breast cancers, something which is known as a prophylactic mastectomy, or at least a very strong surveillance program. Similarly, for ovarian cancers, if she's postmenopausal, we can put them on a ovarian bilateral oophorectomy, which is a prophylactic surgery, and prevent the risk of ovarian cancer by nearly 60 and 70%, which is fantastic. All right, because the risk of that person developing an ovarian cancer is as high as 60 and 70%. I have 3 families right now who are BRCA positive, who have undergone a prophylactic oophorectomy. 3 patients whom have had a prophylactic oophorectomy. 1 patient in the last 1 or 2 months who's had a prophylactic bilateral mastectomy, because the risk was very high. The mother, the grandmother, and the daughter, all 3 had cancers. And for some reason, I don't know why nobody had advised the mother or the grandmother, when both of them had reached, that go into a BRCA mutation. The daughter came to me for the first time. I said, your family history is so strong that we should do a BRCA. I was so sure it would come positive. And the minute it came positive, I said, look, this is what we need to do. We can prevent your future generations from developing this. We can prevent them from going through what you and your mother and your grandmother have gone through. So that is something we need to be aware of. Every patient should be asking his doctor about what is genetics. Am I at a hereditary risk for cancer? That is something that has to be discussed, number 1. Number 2, ovarian cancer. 20% of all ovarian cancers are going to have a BRCA mutation, irrespective of whether there's a family history. So in more developing nations like the UK and the US, every ovarian cancer patient is advised to do a BRCA mutation. Apne yahan pe, I tell all my patients to undergo a BRCA mutation if they're ovarian cancer, because 1 in 5 is going to come positive. And then if she comes positive, I can tell her daughter that get checked. I can tell her sister get checked. I can tell her mother get checked, and I can stop that from happening in them. Unfortunately, in our case, what happens is that the cost is prohibitive. It costs around 15,000 or so roughly to get a BRCA mutation test done. Not everyone can afford that. So I advise it, but half my patients are able to afford it. Half of them are not. So that's a problem.
Is there a specific test for this to identify this?
Just a simple blood test. A simple blood test. That's all it takes.
Okay. Doctor, you wrote a research on the rare case of sweet syndrome in acute myeloid.
It was a long time ago. Yeah.
So can you please elaborate that?
Yeah, but so that has got to do with a very different. So sweet syndrome is a neutrophilic infiltrate that occurs in a various amount of diseases, not just in cancers. But this was a very atypical presentation. My patient had come with absolutely no complaints related to cancer. There were no fall in the counts or anything of that sort. He just had these skin lesions. And he first, in fact, went to the dermat department. We also saw the patient and we said, this doesn't make sense because it's a very rare presentation. We got a biopsy done. The biopsy was not clearly suggestive of cancer, but it said that, he has a very high neutrophilic infiltrate. So we went around that, such a young patient coming with something like this, what is the reason that he has these infiltrates? So we did a whole lot of investigations. I'm quite proud of the way we approached that case. And we then found out that it is an underlying blood cancer, which was missed by the previous, whoever had seen. And it was an underlying blood cancer, which was responsible for all those skin lesions, a very, very rare way for blood cancer to present. And so, so sweet syndrome, but it's not something that we would discuss in, as a routine, because it's such a rare thing. A rare presentation, which is why we made a paper on it.
So are there any rare cases which you have come across in your...
Yes, I mean, so many times. I would say very honestly that I have done far more rare work when I was as a resident in BJ Medical, because what happens is there, our daily OPD was 400 patients. So that 400 cancer patients is just huge. Once you come into private practice, majority of your patients are, the run of the mill. But I have had this one recent, I think it was published in the Times of India, or I think it was published in Outlook, one of the two. a girl who came in at Apollo, a very young girl, 13, 14-year-old, and she only came with her right eye was completely deviated to one side. There is complete blurring of vision and nothing else. And we got all the investigations done. We found that she had a huge tumor in her head. The surgeon said, I can't operate this. The radiation guys said that we can't operate this because the tumor is so big that it will just fry up her entire brain, and she's just 14 years old. So, everyone was perplexed of what to do. We investigated further. We got genetic tests done. We got a biopsy done. We found that it was something very rare known as Rosai-Dorfman's disease. So she had Rosai-Dorfman's disease. I think there were at that point only a few cases reported all over the world, very few from India. I think ours was only the second case from India or something like that. I don't remember, but very rare. And we started her on the treatment. It was all the treatment was experimental. We said that we'll go ahead. Radiation was out, surgery was out. We started her on steroids, and it's been, I think, more than a year. It's been more than a couple of months. It's been a long time since her tumor completely vanished. She's in complete remission. Young girl, she had bossing of the forehead that has completely gone. Her deviation of eye, her whole eye was just shifted to one side, and it's completely back to normal. Her vision is now absolutely 6/6. And so, fantastic. So that we had published that case. So yeah, we do get rare cases. Every once in a while, there's a rare case, but far and few in between now.
Yes, doctor. Okay. So can you please tell me how can patients manage their treatment related side effects? Like after treatment, there are a lot of side effects.
We generally take care of that ourselves. So usually nausea, vomiting, weakness, you will be given medicines for nausea. You will be given medicines for vomiting. You'll be given injections so that your counts don't fall too much. So most of the side effects that occur, the body ache and all, we give aspirins and Dolo and all of that. Most of the side effects are manageable. Look, chemotherapy is not as bad as what it was 5 or 10 or 15 years back. The drugs have improved tremendously. The side effects have come down tremendously. So chemo is not as bad as it once was, but we have options which can even be better than chemotherapy. But side effects by and large are manageable. I don't remember the last time that I really lost a patient to chemo. All right. Losing patients to cancer is something that you have to get used to, because you can't win every battle. We try our best, but sometimes we win, sometimes we don't. But I can't remember the last time I lost a patient because of toxicities related to chemotherapy, because things have advanced so much. And if you take the right amount of care, it is possible to make sure that your patients come out of whatever chemotherapy side effects they may have. Can I just have a minute? I'm about to lose my battery charge. Just give me a second. Sorry.
Yeah, no problem, doctor. Yes, doctor. So as you said that all the side effects are sort of manageable now. So that's a good news. But
they're far more easily manageable. I won't lie. It's not that there are no side effects. Of course there are. Okay. Because you're treating a disease like cancer. If you're treating cancer, the treatment can't be, if the disease is so bad, the treatment can't be so easy. But having said that, do 99.9% of all patients get through it and come out stronger? The answer is yes. Majority of them, I mean more than majority, almost all of them are going to tolerate the chemo. You don't generally end up losing any patient to toxicities of chemotherapy. But it is still difficult. I do not wish it upon anybody, but I promise them that if anybody has to go through it, it is something they will be able to do.
Yeah, from the survivors that I have talked to, they have always said this one thing, that once we were through this treatment, we realized that we can do anything now. So that is something, a difficult journey, but it makes them stronger somehow.
Absolutely.
So doctor, can you please shed some light on Ewing sarcoma and their treatments?
Yes, so Ewing sarcoma is a kind of bone tumor. All right. So the most common bone tumors are Ewing sarcomas, osteosarcomas. These are the most common. I in fact have, ironically, I had 3 bone tumors in my morning OPD today, all 3 young guys. Ewing sarcoma is so I have this girl with an Ewing sarcoma whom I'm treating today morning. I saw her, and a young boy with osteosarcoma that I saw today morning. Both doing fine. But so Ewing sarcoma is a tumor of the bone. It generally occurs in the age group of teens. It occurs in age group of 15 to 20 and 15 to 25. In that age group, it's an aggressive tumor. It's a very, very aggressive tumor, but it's a highly curable tumor. All right. So the basic treatment involves, you start with chemotherapy. You shrink the tumor as much as you can. You do surgery after that for Ewing's tumor. In my case, just today morning's example is a girl who had a proximal tibia lesion. She received 9 weeks of chemotherapy. Post 9 weeks of chemotherapy, the tumor had shrunk fantastically. She went for surgery. She came and met me 1 month now after the surgery. And she's doing perfectly fine. She was only sad when I told her that we still have some chemo left. So she was sad about that, but otherwise doing perfectly well. She's not lost weight also. She did fantastic, in fact. And so the treatment involves chemotherapy followed by surgery if the margins are positive, or if the surgery is not possible, then you might have to consider radiation after that. And then again, you give adjuvant chemotherapy. That's basically how the treatment of and osteosarcoma works. The chemotherapy drugs that are used differ in the two of them. But that's how basically you end up treating a bone cancer tumor.
Doctor, sometimes it also happens in adults, like this cancer, Ewing sarcoma. So how is it different from the usual age group?
All right. So what differs in an Ewing sarcoma? There are two ways in which Ewing sarcoma can present differently. One, it can occur in an older age group, like you just pointed out that it could occur in adults. And two, sometimes, very rarely, Ewing sarcoma can occur outside the bone. This is known as extraosseous Ewing sarcoma, which means despite the fact that 90% of all Ewing sarcomas occur in the bone, there is that rare case of Ewing sarcoma that occurs exactly like an Ewing sarcoma, but it occurs in the soft tissue instead of the bone. So these are two different ways it can present. An Ewing sarcoma in an adult, say somebody in his 35, 40, 45, is unfortunately more aggressive usually. All right. That doesn't mean it can't be treated, but you will be surprised to know that children generally tolerate chemo better than adults. Okay. A teenager has a better shot of tolerating chemo than an adult in his 45, 50. Obviously, an aged adult would, of course, have a much more difficult time. So that makes things more difficult. The treatment per se doesn't differ. It will still involve chemotherapy. In osteosarcomas, it differs slightly. In an older adult age group, you don't use a drug called as methotrexate. You skip that drug. So the chemo protocol changes. In Ewing sarcoma, I by and large treat them the same way because it is a more aggressive treatment. But I've always noticed that adults have a more difficult time tolerating treatment when it comes to Ewing sarcomas, and the outcomes are not as great as, for example, children. Children do much better. Now, this girl that I talked to, or this boy that I talked to, had absolutely no complications. Their counts used to go down, but I never had to admit them post-chemo ever. Everything was managed at home on a phone call, and we managed it each time. And she's doing perfectly fine. Adults generally don't do so well. They have a more difficult time managing, and the outcomes are not so great for Ewing sarcoma in adults. But the treatment remains the same.
Is it because of the immune system? Like as we grow our immune system?
It's a very difficult question to answer. I'll be very honest. I don't want to bluff my way out of it. The reason is something we don't know. We don't know why Ewing sarcoma behaves a certain way in adults and why it behaves a certain way in children, just as we don't know a lot of other things that why, for example, quite simply put, why did the COVID virus not affect children in the first wave? These are just the way nature plays. This is the way biology plays out. It's very difficult to know the answer to certain things, right? But that's the way it is. So similarly, why Ewing sarcoma is more aggressive in adults, I don't have the answer for that, and I doubt anybody does. But the fact remains, it is more aggressive. Whether it is to do with the immune system or whether it is to do with the genetics, I don't know. I assure you, it's not given in any books why.
Okay, doctor, as a lot of patients come to you, can you tell me, like, what are the common misconceptions regarding cancer in the society which you have heard from patients?
So, it's not misconceptions as much, but I would say that what I find very disheartening, especially when it comes to breast cancer, is that many women will tell you that they've had this chhati mein gaant pichle 5-6 mahine se. And it's very sad that they don't tell because they are embarrassed about it, whatever social reasons. Other reasons also are there, but mainly it is social reasons, all right? And I find it very depressing. Because many a times what happens is these are young females who come with lumps in the breast who say that they have had it. Young means I'm talking about 40s and 50s, which is relatively young. And they have had it since 6, 7 months, 8 months. Now, the problem is they will only come to you. It was the size of a pea, and they only come to you when it grows to the size of a lemon or an orange, right? And then they will tell you that we had known about it, but no, I didn't tell anyone and I kept quiet about it. And the problem is if the cancer is spreading on the outside, it's also spreading on the inside. So what was potentially a stage 1 cancer and definitely curable will unfortunately be a stage 3 cancer. And if you are really unlucky, it will be a stage 4 cancer. And that is very disheartening. I feel very bad when that happens, when a relatively young individual knows that he has a lump or something which has to get tested and they don't do that. So that is one thing I find very disheartening. The other thing which I feel is grossly lacking in our country's screening programs. A mammography is a very simple test. Okay, a mammography is just removing an X-ray of the breast. In the US and the UK, 85% of all breast cancers are diagnosed on mammographies, which means that they are diagnosed either in stage 1 or maximum stage 2. Because if a cancer is found on mammography, it's not going to be a big lump. You can't even feel it. You have just found it on an X-ray. So in US and UK, after the age of 40, screening mammographies are done by everyone every year. Once a year, it's a simple test. The problem is in our country, no one does that. So in our country, I can't remember the last time that a lady has come to me with a screening mammography and said, "मैंने mammography की थी, उसमें ये गांठ मिली है." Maybe 1 or 2 patients. They will all be ladies with huge lumps, and it's always in stage 2, stage 3, and sometimes stage 4. So screening mammography, I wish that the government would promote it more. I try my best, but that is one thing. The second thing is cervical cancer. Cervical cancer is the only cancer in the world against which there is a vaccine. All right, it's the only cancer in the world. There is a vaccine available for cervical cancer. It's a WHO promoted vaccine. There are around 70, no, it's more than that. There are now around 100 countries in the world which have incorporated the cervical cancer vaccine, which is either Cervarix or Gardasil, it's known as a part of their national immunization program. Okay. India has the highest number of cervical cancer patients anywhere in the world, and we still haven't made it a part of our national immunization program. I just fail to see why. I'm not blaming government A or government B. It's all governments. All right. It makes no sense. It has brought down pap smear, which is a very simple screening test that every woman should do after the age of 30. It's just once in 3 years. It costs some 700, 800 rupees. That's it. Once in every 3 years, you have to do a pap smear. It will diagnose cervical cancer on an average of 5 to 10 years before the cancer actually takes place. That's incredible. Pap smear, along with cervical cancer vaccination, has brought down the cancer incidence by 90% in developing nations. India has the highest number of cancer patients, cervical cancer patients, anywhere in the world, and we still don't have it as a part of our national immunization program, which 100 countries over the world do, and we still don't do pap smears regularly. So that is things where we need to make a difference. Forget about immunotherapy and forget about hormonal therapy and targeted therapy and all of that. Those are fancy words, and a large number of your population, despite everything, is never going to afford immunotherapy. But can they prevent cervical cancer from occurring? Absolutely. That you just have to spend 800 rupees once in 3 years. So that is where I wish that people were more educated. That is where I think that we need to focus on. So screening of cancers and cancer prevention, it should be the goal, and cancer treatment should be a secondary outcome.
Even I was not aware about the vaccine that we have available for this cancer. Like right now, I'm shocked that there is a vaccine for this. So that's a news, and I'm sure a lot of patients will get to know, and people will get to know that they can get this done. Is it available in India? Like
Absolutely, it's available everywhere. It's very easy to take. It's exactly like taking your hepatitis B vaccine, and it costs also exactly the same.
It's not common because I've never heard of it. Like I have heard of
it's the lack of awareness. It works best in the age group of 9 to 11 years, 9 to 14 years is the best age group. But up to the age of 35, you can take it. It will be efficacious, although the efficacy keeps going down. So in majority of the nations that I talk, 100 nations, it's a part of the national immunization. Just diphtheria, polio, DPT ka vaccine lete. Similarly, when the girl is 9 years old, they will go tell her that now it's time to take your HPV vaccine. That's how it works.
That's an amazing development if India does adapt it someday. So that will be an amazing development.
In private clinics, a large number of people have started doing that now. So the doctors going to private, and patients going to private practitioners and taking cervical cancer vaccine is happening. But it needs to happen at the government level.
Okay, doctor, I just have last question for you. As you've recently joined Zenonco.io, so I just wanted to know that how do you think that Zenonco.io is helping cancer patients?
Yeah, I'm not going to bluff. I really don't know much about it. So I'm hoping that, look, I hope that it helps. I think cancer patients are some of the most difficult part of their life. It's the worst phase of their life to be in. It's not just for the patient, it's also for the patient's relatives. It's a very difficult time. I feel for all my patients. I can't imagine what they go through. I think that they are all awesome and they are superpowers. You need to be really strong to go through the kind of things that they have to go through. The treatment, the emotional component, the financial burdens are ridiculous. All right. If you want to do it in private, the cost, I'm saying this despite being in probably one of the biggest private hospitals in the country, that if you want to do it in private, the costs are ridiculous. If you want to do it in government, the waiting is ridiculous. And the patient is just torn in between. Anything that gets patients treatment more easily accessible, any platform, whether it is Zen Onco, anybody who is doing something to make treatment more easily available, or at least treatment options more easily available to cancer patients, is doing a fantastic job. In that case, I wish Zen Onco all the best, and I'd be very happy to support them in any which way.
Doctor, is there anything that you would like to suggest to cancer patients who will watch this video, like some tips to do or something like that?
I would simply, at given the current situation, only recommend that all cancer patients in general, if you haven't discussed, please go and discuss with your oncologist about the COVID vaccine. So, that's a plus absolutely priority. And that would be the most important tip I can give considering the situation. Discuss with your oncologist whether you are the right candidate, whether you should be taking the COVID vaccine. In all likelihood, the answer would probably be yes. Ask him when is the best time to take the COVID vaccine if you're going on chemotherapy. This is something very important. You should not be left out in the COVID race.
Does COVID affect cancer patients differently?
We really don't know the answer to that. I've read reports where one patient with lymphoma whose cancer completely disappeared after he developed a COVID infection. But that's a really rare case that came in, I think, BMJ. It was in British Medical Journal. But having said that, we really don't know. At present, I don't want to speculate. The answer for now is probably not.
Okay, doctor, that's it from my side. So thank you so much for your valuable input and for being with us during today's knowledge sharing session. You took time out of your busy schedule to be with us and to share so many insights. So I'm sure a lot of people will benefit from this session. Thank you once again from Zenonco.io and Love Heals Cancer for this insightful session on our platform.
Absolutely. Thank you.
Thank you for joining us.